Hello everyone, myself Dr. Biswajit and I will be discussing about calcium reservoirs. Coming to distribution of calcium, total body calcium is 1000 gram, of which 99% is stored in the bone and teeth, and the rest are present in the extracellular and intracellular fluid. Normal serum calcium is 9 to 10 milligram per deciliter, and ionized calcium is 50% of the total, so 4.6 to 5 milligram per deciliter. And if we want to convert it to millimole per liter, we have to multiply by 0.25 as a conversion factor. Extracellular calcium is important for us, of which 50% is ionized form and rest 50 is non-ionized form, of which mainly 41% is bound to the albumin and rest is bound to the anion like phosphates and sulfates. But the protein binding of calcium can be influenced by the pH level. So in metabolic acidosis, there is decrease in the protein binding, leading to increased ionized calcium level. And in similarly metabolic alkalosis, there is increased protein binding, so leading to decreased in the ionized calcium level. Another important thing is we must before correcting the calcium, look for the albumin level. So corrected calcium is the measured calcium plus 0.8 into 4 minus the measured albumin. So if a patient having albumin of 2 gram, then 0.8 into 4 minus 2, that is 2 into 0.8, it is 1.6. So we have to add 1.6 to the measured calcium to get a corrected calcium level. Calcium is regulated by the mainly three hormones: parathyroid hormone, vitamin D, and calcitonin, and also by the parathyroid hormone related peptide in malignant cases. Now coming to homeostasis. A parathyroid hormone act on the bone into resorption, so calcium will facilitate to the blood. So increase in the calcium. In the kidney, it will reabsorb the calcium in the distal converter table, leading to further increase the calcium level in the blood. And in the kidney, it will promote the excretion of phosphate. Similarly, parathyroid also increase the hydroxylation process, leading to increase in the calcitriol action. So calcitriol act on the gut, leading to increased calcium and phosphate from the gut absorption. Now we can uh, summarize in a tabular form. So parathyroid hormone increase the calcium but decrease the phosphate levels in the blood. Parathyroid act on the bone by resorption process, and in the gut it will indirectly affects by the increase in the calcitriol level, and in the kidney it will promote the calcium reabsorption and phosphate excretion. And similarly calcitriol, it will both increase the calcium and phosphate level in the blood through rank mediated increase in the bone resorption, and in the gut it will increase calcium and phosphate absorption, and it has no direct effect on the kidneys. Similarly calcitonin level, decrease the calcium and phosphate both, uh, and the bone it will inhibit the resorption process, and it has no direct effect on the gut, but in the kidney it will promote the calcium and phosphate excretion. So role of the calcium, it helps in the coagulation process, muscle contraction, neuromuscular transmission, messenger in the intercellular transaction, cardiac contractility and bone formation, and maintenance of the plasma membrane stability. Now first we'll discuss the first disorder, hypercalcemia. When the total serum calcium is more than 10.2 mg per deciliter or ionized calcium is more than 5 mg per deciliter, mild form is the 10 to 12, moderate is 12 to 14, and severe defined as more than 14 mg per deciliter. And hypercalcemic state is defined when there is severe neurologic and cardiac arrhythmia is present with the serum calcium level of more than 14. Coming to signs and symptoms, in GI we get nausea, vomiting, abdominal pain, and constipation. In renal, there is polyuria, dehydration, leading to renal failure. In neurologic, there is confusion to coma. In cardiovascular, we typically get the short QT interval in the ECG, and there is variable AP blocks. Here is the there may be there you can see arrhythmia. There is a short QT interval, and we get the Osborne waves, the J waves in the QRS, and in between T waves. We get the J waves, which is not the pathognomic of hypercalcemia. Then what invasion we will send? We send the parathyroid, vitamin D, radiography, and as per the primary disease. So if a patient with hypercalcemia, how will you evaluate? First, we will measure the parathyroid level, and are supposed to be the parathyroid level must be elevated in hypercalcemia. So there may be hyperparathyroid state. Then can be there is four causes like primary hyperparathyroidism, familial hypocalciuric hypercalcemia, tertiary hyperparathyroidism, and lithium use. We can differentiate between the first two by the measuring 24-hour urinary calcium. If it is more than 200 milligram 24-hour urinary calcium, then it is primary hyperparathyroidism. And if it is less than 200, then it is familial hypocalciuric hypercalcemia. Then if parathyroid level is decreased, then we may measure vitamin D level. And if it is elevated vitamin D, then there can be vitamin D intoxication. There can be granulomatous disease like sarcoidosis, lymphoma, so that there will be exogenous vitamin D level increased. Or there can be parathyroid. If it is vitamin D level not elevated, there may be parathyroid related peptide like in malignancy or in bone resorption cases and decreased calcium restriction cases. We will be discussing later. So basically etiology is parathyroid hormone dependent mechanism like I've already discussed. Primary hyperparathyroidism 85% is because of the adenoma cases, and also by hyperplasia, and carcinoma is very less common, and familial hypocalciuric hypercalcemia. And vitamin D dependent mechanism like excessive vitamin D intake or glandular disease like sarcoidosis or lymphoma. And independent of vitamin D and parathyroid level is like parathyroid hormone related peptide for formation in malignancy like PCA breast, squamous cell carcinoma lung, and renal cell carcinoma. And increased bone resorption like in immobilization cases, Paget's disease, osteolytic malignancy, and hyperthyroidism cases. And decreased calcium excretion in volume depleted condition, thiazides use, and milk alkali syndrome. So now coming to treatment. Treatment is disease specific. If there is adenoma of the parathyroid, then we have to surgically remove. So and another is increase urinary calcium excretion by diuretics and dialysis. And third one is we can decrease the further bone resorption by the use of calcitonin, bisphosphonates, and steroid. So how to increase the urinary calcium excretion? So we can use saline diuresis by uh, normal saline 250 to 500 ml per hour to maintain a urine output of 100 ml per hour. But caution in the elderly, CKD, and heart failure patients. And we can use diuretics. Only furosemide can be used 20 to 40 milligram IV second to third hourly. We should not use thiazide as it will rather increase the reabsorption of the calcium. And diuretics can be used only if patient got hydrated adequately. And in resistant cases, refractory cases, we can use hemodialysis. And also in patient having CRF. Another way is we have to decrease the bone resorption by using calcitonin 2 to 4 international units per kg subcutaneously 12 hourly. It has already onset of action, but patient develop tachyphylaxis. Second one is bisphosphonates. We can use zoledronate 4 to 8 milligram IV over 15 minutes can be repeated in 7 days. And pamintronate 90 milligram IV over 2 hours. It is single dose. And onset of action of pamintronate is after 12 hours. Peak action in the 4 to 7 days. So the correction will be later. So we must first diuresis the saline and hydrate and diuresis the patient. Then we can use permanganate as the peak action will be late, but it has nephrotoxic property. We can use glucocorticoids like prednisolone 40 to 80 milligram in lymphoma cases, sarcoidosis cases, and denosumab is a monoclonal antibody against the rank ligand. So, but it is used only when refractory to patient is refractory to bisphosphonates, and dose is 60 to 120 milligram subcutaneously every 4 weeks. And it has also onset within 3 days. Disease-specific treatment like discontinue the culprit drugs, surgical treatment in primary hyperparathyroidism like in surgical removal of the adenoma, parathyroid adenoma, and specific treatment in case of malignancy and granulomatous disease. Now, second disease is hypocalcemia. So, when the serum calcium level is less than 8.5 milligram per deciliter or ionized calcium is less than 3.4. Etiology says, like in hypercalcemia, we divide it is low parathyroid level induced cause like parathyroid agenesis, parathyroid destruction by surgical means, radiation, tumor infiltration, or autoimmune mediated, or reduced parathyroid function like in case of hypomagnesemia state. And high parathyroid level causes are like vitamin D deficiency means by nutritional renal insufficiency like in CKD patients or vitamin D resistance state like uremia and drugs like calcium chelators um, and bond resorption inhibitor like bisphosphonates and increased vitamin D metabolism in phenytoin and ketoconazole if patient is taking. In these cases, there may be acute pancreatitis. There is release of lipase which increase the free fatty acids, which are the negative ions which attract the calcium. So calcium will decrease. Similarly, in acute rhabdomyolysis and tumor lysis syndrome, there is increased release of the phosphates, which is leading to decrease in the calcium. And in osteoblastic waste, there is increased calcium demand in the bone. And in massive blood transfusion, there may be increase in the citrate level, which correlate with the calcium. Now coming to clinical manifestations, in mild form there is usually asymptomatic. We can get incidentally. In the moderate form there is paresthesia, mainly in the circumoral region. There can be chopstick sign and prosive sign present. And in severe cases there may be seizure or corporal spasm, laryngospasm, which is life-threatening, and prolonged QT interval. Here is the prosive sign. If we inflate the BP cuff more than the systolic blood pressure, then there can be flexion of the wrist and metacarpophalangeal joint and the extension of the interphalangeal joints with flexion of the thumb. And in the chopstick sign, there is spasm of the facial muscle when tapping over the facial nerve in the zygomatic arc. So how will you evaluate a patient of hypocalcemia? First, similar according to the hypercalcemia, we measure the parathyroid level. If it is low, which is supposed to be, then there may be hypoparathyroid state in hypo or hypermagnesemia or parathyroidectomy or autoimmune disease or infiltration to the parathyroid like in hematochromatosis, Wilson's disease or radiation induced destruction of the parathyroid gland. And if the parathyroid is elevated, then parathyroid is present, that means parathyroid present but not effective. So we measure. Next is vitamin D. So if vitamin D is low, then there is vitamin D deficiency. It can be low dietary intake, severe liver disease, or P452 enzyme inducers like patient taking phenytoin, phenobarbital, isoniazid. And if it is vitamin D level is normal, then the cases parathyroid resistance cases like uremia environment or bisphosphonates, then chelation cases like hypophosphatemia and pancreatitis, alkalemia, or phosphonate therapy. So what investigation will send? So serum calcium total and ionic, serum albumin, serum phosphate, serum magnesium, renal function test, serum parathyroid, vitamin D, and ECG. So hypocalcemia in critical ill patient, mainly we have to measure there can be C2 hypocalcemia. So we measure the total and ionized calcium. Usually the total serum will be low in the critical ill patient. And in critical ill patient like in pancreatitis or in patient having rhabdomyolysis, hemolysis, and massive patient having massive blood transfusion, there can be chelation problem. So that is decrease in the ionized calcium. And in sepsis case, there in mainly in the gram-negative sepsis, we are having low parathyroid hormone and low calcium, leading to hypocalcemia. So treatment after the treatment depends on the severity, rapidity, and having the accompanying complication like seizure and laryngospasm. In severe acute hypocalcemia, when this calcium is less than 6, uh, we can use calcium gluconate 10%, 2 gram in 50 ml. 2 gram means 2 ampoule in 50 ml, 50 ml NS, or 5% dextrose IV over 10 minutes. We should must avoid the ringers lactate as dilute, as lactate is present as a constituent, so it will form calcium lactate. Another one is calcium chloride, same 10%, but we can use lesser quantity 1 gram in IV over 10 to 20 minutes, because calcium chloride having 3 times more calcium than the calcium gluconate. So again send serum calcium twice daily, and if still hypocalcemia persists or signs and symptoms there, then we have to infuse 5 gram of calcium gluconate in 500 NS at 50 ml per hour. And 1 gram calcium gluconate having 93 elemental calcium, and 1 gram calcium chloride contains 272 milligram of elemental calcium. So which is 3 times. In moderate to mild hypocalcemia, there is 1 to 2 grams of calcium tablet can be used per day. And if there is vitamin D deficiency, we can use calciferol 50,000 units weekly once for 6 weeks, which is followed by the maintenance dose of 800 to 1000 units daily. And more active for calcitriol we can use, and the dose is 0.25 to 2 microgram per day for 4 to 8 weeks. And we must supplement the magnesium when there is a magnesium deficiency. Thank you.